And he presented it. So I thought that would be very useful for us to share. Okay. So let's get going. So, okay. So this is a 54-year female patient who was referred to the Hebron Hospital in Cambodia with the symptoms of 3 years palpitation that gradually worsened last few months. Lately becomes almost daily. Duration of palpitation lasts 1 hour also, especially during the evening and night. And no associated medical illnesses, no prior hospitalization or surgeries, no routine medication, no allergy. What I understand that there's no family history of cardiac arrhythmia. Physical examination is moderately overweight, but no deformity. Necessary otherwise normal. Okay. This is a chest section of this patient. So you can see it. Patient is relatively bigger. Look at the most of our Southeast Asian, they tend to be smaller, thinner lady. The cardiac chamber is just normal. There's no other lesions in the lung field. Chest X-ray quality distant to interpret. Okay. So this is EKG that she presents last year. So the Hebron Clinic. So you can see that clearly what we're excited for, right? But rate is relatively slow, right? So about 60 or a little less than that. So if you look at the delta wave, that is kind of a little bit negative in lead one. So when you look at the surface ECG in probably the pre-excitation, pay attention to especially the vector of the first 40 milliseconds. Because sometimes EKG is not fully manifest. You may not be able to see delta wave precise. So first 40 milliseconds delta wave would be would be important. Okay. So negative one, clearly negative in AVL, right? And then you got a little bit of a wide pre-excited complex. And then V1 is a positive through the V6. So where is the pathway, fellows? Where do you think that this pathway is? We talked about this last time when you asked them that. So patient delta wave is a negative in AVL right here. Okay, go to the line. P is right in front of it. Remember we talked about that delta wave is located whenever the delta is a negative, most negative area. You asked me that question, where it is, in AVL. So it's the left side, lateral, actually pathway, plus. Okay. So what is unusual about this? Let me answer that question now. Do you see left side pathway such wide pre-excitation? Do you see that or no? So fellows, I want you to think about that. Okay. All right. So this is they took the patients to the lab, they did EP study. So you have a LA view, basically. Coronary sinus catheter, radiator catheter, so dodeca catheter, is bundled and IV. Okay. First comment that I have here is that if you're thinking that the patient has EKG pre-excitation over here somewhere, left side, this distance to here is very long compared to the outflow tract will be over here. So your IV catheter should be placed in outflow tract, not in the inflow. Because you want to pre-excite this guy. You don't want the patient go far away, so you're sort of merging with the sinus, then you be concealed. Then depending degree of pre-excitation, you will have a less pre-excited complex. Your EKG interpretation may not be proper. Okay, so left side X-ray pathway, ordinaries. If you have a look at the LAV mitral and it's like this, 4:30 o'clock, right around here, this way, inflow pacing, this way, outflow pacing. Okay, simple as that. Because remember, pulmonary artery comes out this way. Okay, remember, RV outflow, right? LD comes this way, so they're crossed, right? So your pace, RV outflow tract will be closer to the left side. Your pace aorta will be far away. Okay, that's the opposite. because of your great cardiac veins, embryologically, they rotate counterclockwise in the formation. That's why pulmonary artery become front, aorta become back. So this is based on heart rate pacing, non-pacing, and then you have a clearly fixated still, intracardiac signal, nice and well recorded, but you have a big sponsor spike, delta negative, right? Cardiac negative, delta, right? HV negative, right? Great. Not all stable, but there's one response potential similar to them. You can see it. That's expected. Wrong. And then when you pace the HRA 850 millisecond, you're excited. Still have a responder, okay? Delta is negative. Then when you pace 800, narrow. Now you can see better responder. So basically, anterior conduction of this pathway is not that great. Very weak anterior conduction. And then next to the pace 8, the volume. But when you pace faster, it shows what? ER prolongation. ER prolongation, decremental, antegrade, okay? And then even after pacing, still remain narrow. So this basically will represent because the rate got faster after pacing. So normally when you pace the atrium faster heart rate, what happens with your blood pressure and all that? Especially when you stuck in front of a T wave. Your mechanical coupling of your AV becoming less effective as with the shorter PI. Then you have what? Endogenous column and heart rate stuck on. All right. So physiology. Then also you notice there is a long PAH, which is recommended. So you know there's no other pathway or any other mechanism. Question there, do I even know the physiology? We don't know. Yeah, let's go. And so you pace, 450, you start having what? 21? Okay, because this guy did not conduct, this guy conduct, this guy conduct, right? So this is 21. Now, nothing magic about that. Okay, so then you do extra stimulus now. Narrow complex. Now I want you to see this tracing carefully. What do you see here? Pay attention to his bundle. How many spikes do you see? 2, not 1. Because Dr. Park and I were interested in AV node these days. He might tell me, I'm hooked on AV node now. Yes, I am. But look at that. This is normal. Split his bundle. What does that mean to you, fellows? Split his bundle is his bundle. This bundle conduction usually one single spike, very sharp, high frequency signal. But I see 2 his bundle, when you have an extra, what's the delay between 2? So this is decremental conduction where? Intra-Hisian conduction delay. This is normal. How many people this is possible? He's a decremental.
So that we reported occasionally.
Right. So basically, when you see a split hiss, typically you will have some abnormal conduction pattern, which I'm going to show you next. So then right after his bundle delay, the excitation pacing complex. That's post-pacing, okay? And then there's a further evidence example of his bundle delay. And then you have a longer delay right here for faster, again, big side still. And then further delay, delta disappear, but the still split here. Time. And then what happened there? Keep going down. Then even longer, 380, watch it. 360, 340. Patient have a AVA, right? AVA. So the echo beat, single echo beat, but not tachycardia. But following is the pre-excitable. Okay, that's important because this reset probably retrograde pathway and able to conduct, okay? And then what happened? 290, maybe not the ERP, but looks like maybe proximal, conduction is higher sure than. And then, one more thing I forgot, interesting about this, now it's fixated this thing, and then it's blocks. When the narrow was conducting, so narrow conduct with echo, even shorter. So what is this pathway doing with the Higgs bundle interacting with the anti-conduction of this pathway and maybe another conduction? So you just think about why is it that had a longer PR and then conduct without significant excitation with the echo bit. Then even 270 pre-excitation, you see this? Pre-excite, shorter AD. Here, narrow, longer AD. So clearly, delta wave doing something to this conduction system. Otherwise, we do not have this paradoxical conduction phenomenon. And then narrow again, blocked, maybe 250. Okay, going down. 230 blocked. Okay. But it's a pre-excited this one. Pre-excites 220. Conduct echo. So they do exhibit such a bizarre paradoxical conduction patterns interacting with the pre-excitation. And this is 210. Now the narrow conducting again. Now ERT. Okay. So now this is basically you're looking at the first spacing. Okay. Let's go down further. This is what? 1 give up. Okay. Because the first bit conduct, block, conduct, block, right? So let's look at the bigger speeds. Okay. So this is the first bit, double potential, conduct, second potential, conduct longer between inter Higgs bundle block, third blocked only the proximal. Okay, right here. And then back again. So there is a Wenkiba at the Higgs bundle inter-Higgs and Wenkiba. This is very rare to see, but do exist. Okay, so that's the only reason I brought this tracing. It's not common to see Higgs and Wenkiba. I've seen only in my life. This is the third time I'm seeing it. Okay, I would not believe until my mentor showed me. So this is a Higgs bundle intra-Higgs and Wenkiba. That's why patient has such a bizarre paradoxical phenomenon.
Why there
Oh, sorry.
is for H1 and H2 has reversed polarity?
That I don't know that yet. So I'm trying to figure that out, whether this has to do with some sort of concealment or something else. I can't answer that right now. But if you look at the last bit, positive. See here? So some of them are positive. So if you look carefully here, this is a less negative, more negative, more negative. Is that like about?
Yeah.
And then it's now become positive. And I was thinking about that and then for a while, but I didn't have an answer yet. So I hope I come up with the answer. I'll tell you, okay? This is a 2-to-1 block, okay? Faster speed, same thing. You can see, okay, block, conduct, block. So this patient has split Higgs bundle. He has this inter-Higgs and Wenkiba and inter-Higgs and 2-to-1 block. Okay. So same 340, same thing again. Now EAP pacing, eccentric obviously through the pathway, but she never had able to have an echo with the BPs. No VAB response, just VA. That's it. Is it blocked? So obviously, very unusual pathological phenomenon happening, this interaction with conduction system dissipation with the fixation. So, but Professor Hall decided to blame. So he went there, transaxle, beautiful, wonderful job, nice packet placement. And he just a big packet potential right here. This a blazing distal, nice EGM. There's the packet potential. And then he ablated a couple of burn. He was done. Okay. The cessation. Okay. So more important would be the sinus rhythm. Clinical question. What was the unusual about this case? First of all, patient onset of age for patient too old. That is not a natural history of W. If you have a pathway that is a functional, you typically would have expected to have a age of tachycardia, teenage to the early adult. This patient was 50. Dr. Hammond recently case, the patient had a delta wave as well, but the patient had a palpitation, relatively older age. That patient also has to happen to focal tachycardia from home again. That's what I was informed. So when you see older patient having palpitation of a delta wave, also late, you start thinking two possibilities. One, patient have a coexisting tachycardia, something else triggering this, or patient have a avial conduction disease like this patient. So here is the disease for this favor, this conduction here. But that doesn't explain this patient either, because patient never had a documented tachycardia before the lab. Just had a symptom of palpitation. Secondly, patient have a palpitation at night when sleep. That's another unusual feature of this. AVNRT, yes, I might argue, but not AVRT. Very unusual. AVRT, more activity dependent tachycardia. AVNRT is more vagal dependent tachycardia, therefore tend to happen during the sleep, at REM, and so on. So there's a few things that are really unusual, particular about this case. And patient split is, a conduction, paradoxical conductions, all these things we see. So, and patient never had a DAB response, only AVA response without induced fluid. So next question to you clinically, when you see this, based on all the information we have, do you want to ablate this pathway, or we should pursue inducing for the additional tachycardia? That's something I think I leave it up to you guys think about it. Yeah, so I wasn't there, so I cannot tell you what the whole story is. But indeed, the patient actually had AEF, he was about 340. So he did ablate. I think he's fine. Since he's there, might as well get rid of it because for future posterity. But do we answer her questions into the palpitation? What is the etiology? I don't think we did. Okay. In other words, if you have whenever see such an old patient, you don't know the diagnosis, make sure document clinical tachycardia over these questions. Okay? Don't assume it does optimal. So whenever your patient presentation history is atypical, you want to do monitoring much as you can to document the clinical episode, bring to the lab, and then study and ablate to get this out. That would be very helpful. That's the whole point here. Any other question? Any question?
I
Please.
have a question.
Yes, please.
Why is H1 interval is so short?
AH interruptor short. I don't know that.
H1.
Yeah, because the baseline when his bundle split. His bundle H1 and an AV conduction is maybe enhanced the causing block. They report the case, but I don't know what's the mechanism now. You know, I was just talking about Dr. Bug about that. If you look at the Bob Anderson's pathology paper, human most significant, I understand not all, but most significant number of the neonate stage pathology specimen show the compact node is not condensated yet, it's scattered. He also found several, pathology specimen where the his bundles are also even scattered, not completely emerged, the converted condensed. So he got the name of condensation of AV node region. So you find a significant babies without condensation. That might explain why you have a tweak. His bundles, right? Also delay, block, and only impact is delay as well. Other potential option is that maybe we're talking about crazy hypothesis that I thought about it. We do think, at least I think that the AV node is a merging of anterior posterior AV node every human. Okay, like you see twin AV node. Because if you look at the even lung and the perfusion of adult human, the AV node, anterior AV node behavior, cellular physiology, ion channel mechanism, posterior, completely different. One is a connection based, the other was HCN based. So, I'm wondering whether there was an incomplete, almost complete fusion, but not quite complete fusion. So let's say you have a split AV node like this. Then depending on the conduction velocity, you may have a two different equation wavefront. Then you may potentially have a double potential. So And then also part of the explanation of that is the CS and AV node patients are larger than AV active patients. So therefore, they're separating two input. That hypothesis is correct or not, we don't know that yet. Only argument I have for that is that, patients have a multiple heart, basically has twin AV nodes, but that common single his bundle connection down further down to ventricular septum. Even though some of those patients are VSD. So his argument is that anatomical incomplete merging of the truly confinement of the region plus posterior input. That is possible, we don't know, but I do know there is a non-condensation heart exist. And Bob Anderson think that when you have a non-persistent or non-condensation of AV nodes, favor for develop a node ventricular pathway, node ventricular pathway, because the muscle fibers still persistent. He argued about that. I was reading about that because we are writing right now. Node ventricular pathway paper, and I read many of this. That was quite interesting.
So the H interval, the polarity change and the delay during the atrial extrasystole. That means the two his bundle potential is not existing in a line.
Right.
Right.
Oh, could be one
Some-
block depending on.
Yeah, some wavelength detour the.
That's why I was
History.
like,
Yeah.
that's what the reason I am talking about the Bob Anderson's paper.
Yes.
So I think infrahistory nodal conduction. I can imagine this between these two potential, they gotta be myocardium. Otherwise, I can explain just why the decremental, why the wing tip, why the polarity reversal. Or I won't go that far because I don't know the answer. Since your keys can be like the disconnect jumping phenomenon. And then between the two, split whatever his bundle, there may be some interface myocardial locks in this particular patient. So would it be genetically abnormal to be?
Sometimes we see the patient structure normal apart AV block sequence normal.
Yeah.
But during decurrent appropriate AV node conduction, HB interval probe.
Wrong.
So my hypothesis, if my catheter, his bundle catheter is the right position of H2, his recording, H1, his recording side.
Right.
In those patients, even though it is normal conduction, it could be shows a
Right.
HB prolongation.
Right, prolongation, they maybe have decremental tissue, they will split it in myocardium there, or some sort of a nodal tissue. Embedded in that area. So it is a fascinating area, I think, worth to review at some point. And I asked, Dr. Kim of Yongin, standard case of that AV node with a short PR, double potential is. You had a case also, so maybe good, cases to review and discuss about it. Could be a case report also, because this is something that everybody have not seen all. So, okay,
You told that the WPW syndrome shows ABRT in young age, but theoretically, as the patient getting older, AV node conduction delay
right,
and make their
excited.
more the excitable, longer excitable
Right.
get
It
it.
doesn't, it did not have it.
So
That's because I think it should did not develop because it's one of disease. That's what I think, okay? Otherwise, we do not have this parallel free excitation to conduction, never complex, no conduction, so on, right? So I can explain that. I think she did have a paradoxical behavior, response conduction system, which is that protective metabolic. Luckily, she had also very long anti-conducting ATFP. So she has no risk of developing AT because of sudden death either. So she will be pregnant to develop AT because overweight. So, but she did.
too. If you see this kind of patient without the documentary with SVT, will you rate it or not?
I think there is no documentary target. I will not probably.
You will not. Okay, how about you?
Never.
Never.
Never give up.
Never always.
I think if I'm the same case, I have same case,
Yeah,
I would like to
yeah.
avoid it. Because the old age has some people vulnerable to atrial fibrillation and the risk of sudden death.
But the
Even
people
though
have
we
something
didn't
that-
see the ERP.
800 milliseconds.
So
Yeah.
these little nerve.
Yeah. So I think, even this patient develop AFib, we're not gonna be very fast because we get this pump disease. So I think, question is that whether presence of WPW would enhance even occasional VA conduction, would aggravate the atrial fibrillation mechanism. That would be I, right? Because it would be another source of extra piece, so. But I don't know whether, anybody ever documented that as a case. But
But the
we-
catheter is already in.
correct. No, that's what.
I don't want to waste
Yeah,
it.
that's the reason I brought this, I thought about this case, I wondered. Should you oblate, yes or no? That's why I bring this question, because I don't know myself answer, okay? But,
Bottom line, cosmetic purpose.
it's not a cosmetic purpose, no, it's not a cosmetic, because she has a single equity. We know we can retrograde fit in, right? So. It is the more than cosmetic issue. So she developed another mechanism tachycardia with the interaction of the AVA response to the interact with the other focal tachycardia aggravated tachycardia percent, which it can be because you have wave collision and so on. So having more additional extra input to the atrium is not always a good thing to have anyway. Knowing that, I think I would answer this question this way. If you have a confident to be able to do good transeptal without intraoperative echo, you'll feel comfortable, yes, why not? You're there, great. You got the ablation catheter. But if you're not skilled, doing transeptal without echo and so on, then you're gonna walk away. It's all dependent individual level of skill as well. It's not just the slam dunk. Everybody can do it, I can do it. No. Worst thing will be cause a complication in this patient, then you have no way back with that. Okay. So look at your skill, safety margin of your room, your facility, everything else, put in the equation, the design. That would be, I think, the right answer. Okay.
I will watch you.
Let's do it.
You will really oblate or not.
Maybe. I, as you know.
Anything else? I just brought some cases from Cambodia because they showed to me. It's like, wow, what we should do when we in Korea, and what I would tell my colleagues and fellows, what we should do. There was some sort of a thought about this. I said, well, let me show. This is very unusual to see his mother will give up to 20. Okay.
I will ask one more question.
Yes, please.
Even though it is not a scientific question. How come the Cambodian electron is so clean? Better
Oh.
than ours.
Well, I don't know that because we set up the lab. Okay. Or you want to make sure there's no noise? No, I answer for you only one answer. This lab is in the ground. Okay, the wall ground. That's the only thing I can tell you. The EP lab should be underground or first floor. So you can have a separate ground and cable through the earth. Mothers help you. Okay. If you're third floor, it's very hard to drag that cable down to the ground down there.
Better electron than ours.
They would think that these guys are crazy if we ask them to that, engineers. But,
You got
I get that.
electrical burn.
yeah,
During
but I did, in my labs, even though we are third floor, second floor, we didn't care. We made a hole through the window with another copper cable all the way down to the ground. I made to make sure that, because I want to see when I ablate that EGM. Your noise, yes, when you ablation, no, that's not acceptable. Not for the first class lab, no. Because you want to see whether your ablation creating lesion, yes or no, because you want to stop early, you don't want to wait. Or let's find out it's burning 30 seconds, see that that's no good. Okay, you don't want to cause a damage to the heart muscle if you're not successful, there's no point. One of the criteria of a good quality of lab would be that your ablation EGM should be cleaned with the burn. So you can see the lesion formation, loss of whatever type of potential, how many seconds, and so on. If you don't lose a few seconds, you gotta stop and just keep burning while you burn sphere that you don't need. So those kind of minor, meticulous detail attention help your patient. Okay. Thank you for everybody.
Very nice.
Okay.
Thank you so much.
You're welcome. Important fellow you stayed, I gotta give you, first practical lectures. Well, nobody living, why you guys not living? Oh, but you guys should go.
Everybody is expecting yours. So
No, no, I'm
third
just
lecture today.
No, I'm just giving